This region is mostly studied by this axial cut. Here we can see all its structures. So coming from outside in, we can see the first layer is a gray matter layer. This is the insular cortex. Then directly underneath, we have the extreme capsule, then the claustrum, then the external capsule. Medial to the external capsule, we'll have the putamen with its shape like a lens, the lentiform nucleus. And the lentiform nucleus is subdivided into the putamen, that's the most bigger one and most lateral. And then the small globus pallidus, that's medial and a little bit more basal than the putamen. Then more medially, we'll have the internal capsule. The internal capsule is subdivided into 5 segments. It has one anterior limb, a genu, a posterior limb, and a retrolenticular segment, and a sublenticular segment that we cannot see here, but it's underneath the lentiform nucleus. Then here is the head of the caudate, remembering that the caudate is a C-shaped nucleus that's going to wrap around the thalamus. So here we have the thalamus. And it was shown already this close relationship of the foramen Monroe with the genu of the internal capsule, laterally and then medially with the fornix. Okay. So it's interesting that all these, the white matter capsules, they are made with white matter fiber bundles. And as these white matter, these fibers are arising or just passing through the central core, they have to go to the other lobes. They will pass through this small space between the insular limiting sulci laterally and the lateral ventricle medially. So they have to condense all together, creating a very thick and condensed structure of white matter fiber that some authors call this the cerebral isthmus. So it's like we have the central core, and through this white matter, very condensed, thick white matter fiber bundle called the cerebral isthmus, the other lobes are attached to the central core. It's an interesting concept. So here we can see as well, like how the lateral ventricle is going to encircle also the medial component of the central core, mainly the thalamus, creating this C-shaped format around the central core. So here are the fibers arising from the central core. Some of them are arising, or some of them are just going through the central core. But we can make this cut along the insular limiting sulci towards the lateral ventricle, so detaching what is the central core from the rest of the lobes. Of course, we cannot do this regularly and in the patients, although there is a surgical procedure that we do some of like this called hemispherectomy or functional hemispherectomy, where we are going to disconnect the central core from the rest of the brain for Rasmussen disease, for example. And then we disconnect the telencephalon from the central core. Another interesting concept that the central core stands in the middle of the brain of each hemisphere, and it is surrounded by the limbic lobe. So we can understand the limbic lobe that it means around. It means around what? Around the central core, or mainly the thalamus. But the limbic lobe can be understood by being formed by 2 Cs. So it has one external or cortical C, composed by the cingulate gyrus, continuing through the isthmus with the parahippocampal gyrus and then the uncus. This is the outer C. And then we have one internal C that will be made by what is inside the uncus here, mainly the hippocampus, continuing with the fornix, and then finishing in the mammillary body. So here we are detaching this inner C. This image, we can see that we are splitting the fornix from the thalamus. The thalamus is a very well-defined ovoid structure here. And we are just opening this natural space. This is the choroidal fissure, right? Where the choroid plexus is attached. So it has been shown already, but if we open the choroidal fissure on its most superior aspect, we're going to get inside the roof of the third ventricle, If we open a little bit more posteriorly, we are going to get to the pineal region, quadrigeminal cistern, top of the quadrigeminal cistern. And if we open the choroidal fissure more inferiorly, already in the temporal or inferior horn, we are going to get inside the lateral aspect of the ambient cistern, the lateral wing of the ambient cistern. Okay, so here's choroid plexus, here's the hippocampus, and it will continue with the fornix. Everything together is called the hippocampal formation, okay? And then anteriorly, we'll have the amygdala here. The amygdala is not really a well-defined structure. It's just some gray matter inside this most temporal mesial place here, region, but it's not so much well-defined as the hippocampus. Here's another preparation. So we split the sylvian fissure. We can face all the insular surface, and with its limiting sulci, anterior, superior, and inferior, and here the limb and insula. And again, making that cut along the insular limiting sulci towards the lateral ventricle. We are going to detach the central core from the rest of the cerebral lobes. But this most anterior part, anteroventral part of the temporal region will cannot be detached easily. There is not a natural separation between the temporal mesial structures, mainly the amygdala, with the central core. It will continue. So to make this cut, there are a number of ways that people will make this cut to finish the temporal lobectomy, for example, to detach the temporal structures from the central core. But a line that we can use is to connect the inferior choroidal point to the ICA bifurcation. The inferior choroidal point is where the anterior choroidal artery is going to get inside the temporal horn, right? And the inferior ventricular vein is going to exit here. It's directly between the head of the caudate and the amygdala, right? And then if we connect these points, we are going to really make this cut that will make the amygdala stays in the temporal region, and the continuation of the amygdala, that's the globus pallidus, will stay inside the central core, okay? This is the anterior choroidal artery, so this line will follow its trajectory. Other surgeons will try to see this structure here. This is the optic tract, so coming from the chiasm to the lateral geniculate body, okay? This is also the inferior aspect of the diencephalon. The diencephalon we put inside the central core concept, right? It's part of the central core, mainly the thalamus. It's the most important structure of the diencephalon. But there is not a natural division between the mesencephalon and diencephalon. But most people will agree that the inferior aspect of the optic tract will be the line that divides them both. Okay, so here's one anterior view. We have two central cores, one on inside each cerebral hemisphere. And as I said, there is not a natural separation between the central core and the mesencephalon, and most will agree it's the inferior aspect of the optic tract here. Here we can see the MCA arising from the ICA, right? So MCA comes here, middle cerebral artery. It has this M1 segment underneath the insula, and then already over the insula we have the M2. Here's one inferior point of view. So here's M1. M1 will bend at the limit insula and reach the insular surface. Okay. So here we made a white matter fiber dissection. We prepared the brain by freezing it for some weeks and then defreezing it. And what happens is that the gray matter stays very much condensed and very easily to be scraped off. We can just detach it from the white matter. And what happens is that once we decorticate the brain, the first white matter fibers that we are going to face are the short association fibers that are connecting together the sulci, the gyroid, adjacent gyroid, they're putting together. Once we continue the fiber dissection, we begin to see the long white matter bundles. These are the ones that receive names. So this is the superior longitudinal fascicle. And this preparation was made just to show that the SLF will not be inside the central core. Okay, so it's wrapping around the insula, but it's already outside the insula. It's going to connect the frontal regions to parietal and then posterior temporal regions. This is the SLF, and the arcade fascicle is part of the SLF, is the most medial part of the SLF. Now let's fix the insula. Once we decorticate the insula, we are going to pretty much see that the short gyri will meet in the insular apex, while the long gyri will not go towards the apex. They will finish more posteriorly. Okay, and once we decorticate the insular cortex, the first white matter layer that we are going to face, it's the extreme capsule, right? The extreme capsule is made by these short association fibers, the U fibers, that are putting together all the insular gyri together, and also are continuing towards the opercula as well, the frontal, parietal, and temporal opercula as well. Just a note here, here's the Heschel gyrus. So not the central core, but this is part of the temporal, and it's continuing. And as Professor Ribas said, it's pointing towards the ventricular atrium. If we continue the fiber dissection, we remove this first layer of white matter, and we begin to see a very thin collection of gray matter. This is the claustrum. The claustrum is more organized dorsally. We can subdivide it into the dorsal claustrum. This is the real claustrum, the one that really seems like a collection of gray matter. And the ventral claustrum will just give to this portion of white matter here a more brownish appearance, but here it's more subdivided into islands of gray matter at the ventral claustrum. The dorsal claustrum is more organized. If we make small windows at these fibers that are arising from the claustrum, we can already see the basal ganglia that is medial to these fibers. This is the putamen. Okay, but what I want to show in this step of the dissection are the three white matter fiber bundles that we can see here. First, we see the uncinate fascicle. This uncinate hook-shaped fascicle will connect the frontal orbital region to the temporal pole, passing immediately behind the limb and insula. Then we'll have the IFOF, inferior frontal occipital fascicle. We'll put together all these regions here. Okay, this at the left hemisphere has been related to a semantic root of language. Okay, so the IFOF. And then we have some fibers arising from the claustrum. Those are the claustrocortical fibers. We say claustrocortical, but they are in a loop. So it's claustrocortical, cortical, claustral fibers. Okay, so all these three fibers, all these three fiber tracts, they will be superficial and deep to the claustrum. So they will contribute to the extreme capsule and also to the extreme capsule, to both capsules. Okay, so here we remove the claustrum and its fibers. We can see here the putamen. And if we now remove the fibers that here form the IFOF, we'll see fibers that have a different disposition. Okay, so these fibers are crossing from this temporal lobe to the other temporal lobe on the other side. So if they are crossing the midline, they are not association fibers, those are commissural fibers. This is the lateral extension of the anterior commissure. Okay, let's remove the putamen so we can see more of these fibers. These fibers are passing through a channel that is inferior to the globus pallidus. This is the globus pallidus, okay? So it's at the ventral pole of the globus pallidus, there is a channel called the channel of Gratiolet, and this lateral extension of the anterior commissure will pass through this channel, okay? Now, if we remove the globus pallidus, what we are facing here these radial dispositioned fibers. Which are those? Medial to the lentiform nucleus. These are all the internal capsule, right? Here the internal capsule can be subdivided into its anterior limb, then genu, posterior limb, here already lentiform and then sublentiform segments. But they are always radial disposition. This is why the internal capsule will continue outside the central core with another name. What is the name? It's the corona radiata, right? So these are the same fibers, but here they receive the name as internal capsule, but later it will continue with another name called the corona radiata, okay? Here is the internal capsule. And they will continue towards where? Towards at the mesencephalon, the cerebral peduncle, right? The projection fibers will continue downwards through the cerebral peduncle. And at this region here, what Professor Ribas already have shown is that here I spare a little bit of the gray matter that belonged to the putamen. But what I want to show here, take attention here, if I remove this gray matter here, will I face the internal capsule fibers or not? No, not actually. Anterior and inferior to the anterior commissure, we will not have internal capsule. So here at this region, the gray matter that belongs laterally to the putamen will merge medially with the gray matter that belongs already to the head of the caudate, creating here a place that we call the ventralstriatum or the accumbens. This is the region. Okay. Now this is a more further view. We can see all these projection fibers. So here, internal capsule, continuing outside the central core as the corona radiata, right? All these projection fibers. And here we can see this shape, very well-known shape, called the Meyer's loop. Those fibers here, they belong to the internal capsule. Yes, but they are going towards where? Towards the calcarine fissure. So they are geniculate calcarine fibers. Those are the optic radiation fibers. They can be subdivided into segments, Professor Ribas have shown already. But this loop here has its name. It's called the Meyer's loop. And this is what is in danger when we are removing the temporal lobe, for example, or we are getting inside the temporal horn, the temporal ventricular horn here. These fibers will be in danger if we make a cut here, and if we make this cut too posteriorly, the patient will wake up with quadrantopsia or with hemianopsia if we go further back. Okay, now we make a small window here, and this is the sagittal stratum that Professor Ribas already shown. But what we want to show here is that more medial to these fibers, there are the projection fibers that belong to the internal capsule, radiation, optical radiation fibers. We can see fibers with a different disposition, a more vertical disposition. These fibers, they will not belong to the projection system. They will not belong to the internal capsule and corona radiata. These fibers are callosal fibers. They are arising from the corpus callosum. The corpus callosum is medially, but you can see that they have a more vertical disposition. These are callosal fibers, so are commissural fibers. These fibers are putting together, connecting the temporal base of this side to the temporal base of the other side. This is the tapetum. Okay, also belongs to the stratum, to the sagittal stratum. Is the most deep fibers. Okay, and medial to here, we are going to have the atrium, the ventricular atrium. Okay, so since I already removed all those fibers, I can see by transparency here already a nucleus here, C-shaped nucleus that's wrapping around the center here. Which nucleus is this? It's the caudate. Yeah, it has its head and body and tail. And as Professor Ribas already shown, the tail will continue towards the amygdala. You can see here how the amygdala will continue with the central core without a natural separation. I will show this a little bit later then. Okay, so here we open the temporal horn. It's very easy to identify the hippocampus. Hippocampus will, in most of time, have this shape with these feet. It seems like a foot of a lion. Okay, and then anteriorly to this, we just have this gray matter that will continue immediately. These are the amygdalo-fugal fibers, but the ventral fibers. Okay, here's the amygdala, and then continue inside the central core. It will continue with the globus pallidus, which was already removed, which was here. And here I just enlarged all the choroidal fissure. Here I am detaching the central core from the limbic lobe, right? So the hippocampus continuing with the fornix. Okay, vascularization. Most of the brain and part of the central core will have a pattern of vascularization that will come from outside in, right? All the brain has its arteries on its surface, and then will send branches, but small branches that will continue inside the lobes. But the central core also has another pattern of vascularization made by penetrating arteries that will arise from the most proximal aspects of the proximal arteries and will perforate the central core and supply it. This is the circle of Willis seen from underneath. I know it may seem a lot of information, but let's follow here. Here's the ICA. If we follow the ICA here, here's the ICA bifurcation, right? MCA, ACA, anterior cerebral artery. From the most proximal parts of those arteries is going to rise the lenticular striate arteries and will perforate the anterior perforated substance, right? Those arteries here, they will supply the most anterior part of the central core, mainly the head of the caudate, the internal capsule, and the lentiform nucleus. So that's why it's called the lenticular striate arteries. Okay, so let's begin here. Here's the Heubner. You can see here the Heubner arises from the ACA, close to the where the ACOM also arises. Here's the ACOM. Here's the recurrent artery of Heubner and the ACOM here. So let's go to the other side. A1 here, M1 here, then we got to the ICA again. And then let's come here. So here is basilar artery, right? Opening like a palm tree in both P1s. So one P1 to each side. And then P2. What's the difference between P1 and P2? It's the connection with the PCOM, right? Posterior communicating artery. Posterior communicating artery is putting together the anterior circulation, anterior carotid circulation, together with the posterior vertebral basilar system, right? So this is PCOM here and PCOM here. This is a very nice specimen to see how we can have the PCOM larger than the P1. When we have this relationship, this is the fetal circulation, right? PCOM is larger than P1. When we have the other way, PCOM is smaller or narrow than the P1. This is the normal circulation. Okay, but what I want to show here is that from the proximal part of those arteries here, from P1 and basilar apex, will arise most of the posterior perforating substance arteries that are going to go through the posterior substance region, mainly between the cerebral peduncles and the mammillary bodies, and that will supply the thalamus as well. So the posterior part of the central core will be supplied by the arteries that are perforating the posterior perforated substance. Okay, at this dissection, we removed the central core that was toward us. We left the central core to the other side. So here is midline, here's the third ventricle. And what I want to show are here the lenticular striate arteries that are perforating the anterior perforated substance. Will supply the most anterior part of the central core. And then here between the mammillary bodies and the mesencephalon will be most of the posterior perforated substance will be perforated by the arteries that will supply the thalamus, right? This is the thalamus here. And then two arteries arise here, the posterior choroidal arteries. We have the lateral one that will get inside the lateral ventricle, and we have the medial posterior choroidal artery that will have a very interesting course. It will arise here, then it's going to wrap around the mesencephalon, continuing in the quadrigeminal cistern, then over the pineal into the velo interpositum cistern. So here's the roof of the third ventricle, right? Here's the third ventricle. And here is the medial, the posterior medial choroidal artery getting inside here and also supplying the most medial and superficial aspect of the thalamus. Okay. Here's another dissection. Let's continue the dissection. We face the claustrum here, all those fibers. We can separate a little bit the fibers. Here is the uncinate fascicle, hypoph. Then the claustrum was already removed, sorry. This is the putamen. Then the globus pallidus and the anterior commissure here. But what I want to show here is that once we remove those fibers that will make the external capsule, we'll face the lentiform nucleus here, and we can see how those arteries that are rising from M1, they will perforate this region here. This is the anterior perforated substance. They will perforate and continue its trajectory inside the lentiform nucleus. And then after supplying the lentiform nucleus, it will continue more medially towards the internal capsule. Okay? And this name, this perforating artery, is a good name because they really perforate this region. They're really getting inside the lentiform nucleus. So here's the putamen being perforated, you see? The arteries are arising here from M1 or ICA bifurcation, perforate, anterior perforated substance, and continue inside the putamen. Okay, we have one peduncle that's more anterior to the anterior commissure, will supply the putamen, and we have a posterior peduncle that will supply the globus pallidus. Okay, and once we remove, we can see the most inferior aspect of this region. This is the optic tract, okay, and those are the radial disposition fibers that constitute the internal capsule, okay. Here we can see the anterior commissure coming from this side towards the other side of the screen, the other temporal lobe, and here is the ventralstriatum that I mentioned, where the internal capsule is not present. It will continue medially towards the septal region. It will continue without any internal capsule here. Okay. And Professor Ribas also said that the anterior commissure has two extensions. One lateral extension, the most bigger one, the most important one. They're putting together both temporal poles together, but also has one anterior extension that's called the olfactory extension that is putting together both olfactory regions together. Okay, and if we face underneath, what is directly over the anterior perforated substance? These fibers here, this is the ansa peduncularis. These fibers are coming from the amygdala, and we can subdivide these fibers in three fibers. Those are the ventrofugal, the amygdalofugal fibers, the ventroamygdalofugal fibers. We can subdivide it in three. The most anterior ones are the amygdalo-septal fibers, also called diagonal band of Broca. And then the most posterior ones will go from the amygdala towards the hypothalamus and thalamus as well. After supplying the internal capsule, those lenticular striate arteries, they will continue even medially towards the caudate nucleus. This is an image from superiorly. We can see the internal capsule here, caudate nucleus here being detached from the internal capsule, and the thalamus here. Thalamus is always this ovoid structure. And those are the lenticular striate arteries, the most medial segment of those arteries, okay? And this is the Heubner. So the Heubner is the only arteries of these lenticular striate arteries that are not going to do all this trajectory from here, anterior perforated substance, then lentiform nucleus, internal capsule, and then caudate nucleus. It will go directly towards the head of the caudate. Okay, so an infarction of the Hoibner's artery will lead to an infarction of the head of the caudate, right? Okay, we just I want to pinpoint that we could publish these results at JNS. So if someone wants to take a look of these images again, and we proposed also a subdivision of the central core in quadrants, taking taking the course of all the white matter fibers inside the central core as a way to subdivide this region into quadrants. Okay, thank you.